Carol Merton, host of We All Belong, Our Neighbors, Our Community, a new Rogers TV series promoting the diversity of our community in Grey County. Please join me on Rogers TV.
September 30th is Canada's National Day for Truth and Reconciliation, honoring survivors of residential schools, their families and communities, and a reminder to acknowledge the truth of our history. In 2015, the Truth and Reconciliation Commission released a comprehensive report with 94 calls to action, a roadmap towards justice and healing. Learn more and take action.
Hi, I'm Carol Merton, host of HealthLink on Rogers TV. HealthLink connects home, community, and healthcare with interesting topics and speakers about your health and your community.
You're watching Rogers TV. This program is brought to you by Rogers Xfinity, connecting you to more of what you love. Visit Rogers.com for more details.
Hello and welcome to HealthLink, a program connecting home, community, and healthcare. My name is Carol Merton, and today I'm delighted to welcome as a guest Kait Dickinson. Now, Kait has a really long title, and she promised me that it was okay for me to say it hasn't short formed in the time that I originally chatted to her. But Kait is Improving Equity in Access to Palliative Care Navigator through Safe and Sound. Kait, welcome.
Thanks, Carol. Thanks for having me.
Someday you have to show me all of that on a name badge. Really, I'm curious on how you would get that fit in. I'm delighted to have you here, Kait, because this is a new position from my understanding, and I'm wondering if you can tell us a bit about yourself and then what your role is and the services that you provide.
Yeah, so I've been living in Grey Bruce for pretty much my whole life, and I started working in Safe and Sound as a harm reduction support worker. My degree is in equity through Laurentian. And then about the time I graduated, this position came up through Safe and Sound, and it's the funding for the position came from Healthcare Excellence Canada, and so there was a bunch of organizations through kind of the palliative care doctors and Dr. Fenn at the hospital and through the OHT, and there's about I think 15 or 16 organizations involved right now. So before I came along, they had a meeting to kind of decide what they would do for the funding for this, and they decided that they were going to hire a navigator for palliative care, and specifically for folks who are vulnerable or homeless and vulnerably housed. And the position landed in Safe and Sound because often that's where people from all over Grey Bruce end up and using their services.
Yeah. And I know that throughout the program, you said graphics, which is great. But when I looked at the graphics ahead of the program, it struck me. Homelessness is a life-limiting illness, and homelessness is a terminal diagnosis. That really captured my attention. And when we had earlier conversations, we think of palliative care and end-of-life care, but to recognize that that care often is provided in people's homes or through facilities, not thinking about those who don't have a home or a roof over their head. First, can you tell me a little bit about the difference between palliative and end-of-life care, just so we understand, and how it relates to the unhoused or precariously housed?
So palliative care is great for anybody who has, life-limiting illnesses. The goal of palliative care, it's not end of life. We're not hastening death. Palliative care is about bettering the quality of life for folks who have life-limiting illnesses. And often a terminal diagnosis. It could be, within a couple of years. People at end of life, there's different definitions of end of life. Often for folks who are going into hospice, so, it's about 6 weeks, but between 1 and 2 years. But people who have life-limiting illnesses can live for a long time and have better quality of life, depending on the type of care that they get. And you're right, like we do think about people, receiving that kind of care in home, or in hospice. And the reality is that there are a lot of people without homes, and people who are homeless or and possibly using substances, have multiple kind of symptoms, and often the illnesses that they have aren't recognized. There was another graphic that I sent to you that shows that the life expectancy for people who are homeless in Canada is between 34 and 47 years old, which is obviously much lower than the rest of the population. And it's also, important to understand that Indigenous folks as well make up their disproportional amount of homeless folks, and especially in our community as well. And those individuals, they're more likely to have cancer and heart disease and hepatitis C. And often, they're not seeking healthcare because of past experiences that they've had, or maybe it's not their priority. Maybe their priority is trying to find housing, or just trying to be safe and warm and dry in the wintertime. There's all kinds of these things that we call competing priorities, that people, they're not seeking healthcare because of all of these other reasons, that are generally, related to survival, and that, what's important to them is, what's happening today and what's happening at this moment, and it's hard to keep up on healthcare. So we're trying to kind of, bridge a lot of those gaps for folks. I'm trying to do advocacy, take people to those doctor's appointments so that they have somebody there with them, and try to figure out what's really going on with people. It's another reason that it's great that the job's at Safe and Sound. I meet a lot of folks there as well. But the job is, I travel all across Grey Bruce as well. I want to make that clear too. But yeah, being in Safe and Sound, I meet a lot of people from all over Grey Bruce. But you don't really know what's going on with folks unless you're able to sit down and have a conversation with them. And that's something that I think is really important for this program, that I'm able to do that with people.
Now, we will be using graphics, but I also, for those who are listening, but not necessarily viewing the program, I just wanted to indicate, so with the group we're discussing, the categories of individuals we're discussing, 34 to 37 is the average lifespan, compared to the general population, 77 years to 82 years. That's a huge discrepancy. 4 times more likely to have cancer, 5 times more likely to have heart disease, and 28 times more likely to have hepatitis C. So that's really what is meant by it's a life-limiting illness and a terminal diagnosis. Tell me a bit about, take me through a path, about what your day might look like and who you might see, and what services you assist with in your navigation role, so that make it real for me.
Yeah. So every day is a little bit different. Everybody's unique and has unique needs. So I do a lot of driving in my job, because, I see folks in Port Elgin and Wyerton and Meaford, and I go to Kincardine and all over the place. So it's a big map. So of Grey and Bruce counties. So that's a big part of my job. Booking appointments, helping people book appointments, and keeping track of them. Driving them to appointments is a big thing. A lot of people don't even have access to food, especially in the more rural communities. They don't have access like we have O'Share every day in Owen Sound, which is wonderful. And I've been able to partner with O'Share too, and Safe and Sound as well, so that I can help people have better access to food, who maybe aren't in Owen Sound or can't get to downtown. So that's been really awesome. I somebody wasn't able to see, so we went to the optometrist. I've helped somebody set up they were able to get a phone, but they didn't know how to set it up so that they could communicate with people. Um, it's all these, social determinants of health and things that take a lot of time. And when you don't have somebody to help you do those things,
Mhm.
they just, they don't get done, or it's really difficult for people. Like I think of it about as like we all kind of know somebody who has, or we have, somebody who's elderly or needs some or a lot of extra assistance with things. And just think about, if that person didn't have anybody and to help with, all of those appointments, getting things set up in their home. Some people are housed that I work with and in vulnerable housing as well. We do think I've been able to help people set up Meals on Wheels, get people connected to be able to get their taxes done through the United Way. Um, just sometimes just an ear to for people. I like to sit with people for a long time, and you learn more when you're able to spend time with people, and that's something I've been fortunate to be able to do in this navigator role. Um, and yeah, and like I think the advocacy piece is really important too, and helping people understand like what services are available to them. The first thing that I do with a person, I guess I should start with, is that we'll sit down and we'll do a needs assessment. So we go through all kinds of things like where do you get your food? Do you have mental health supports? And would you like mental health supports? Or do you have where do you get your harm reduction supplies if you need them? What healthcare supports do you have currently? And it's a big list of questions, and yeah, and it's generally, we sit down and people appreciate that time that they have to answer those questions and figure it out. And we kind of create a map of what's missing, and, what they have and what relationships are working well and what relationships aren't working well. And then, people have that map for themselves, and it just makes things a little bit easier for me as a navigator as well, so that we can kind of try to close those gaps and help people get the care and all of the social determinants of health kind of looked after.
So I'm going to take you even before you have that first conversation. How do people, how do you connect with people? Like some of them, do you go to encampments? Do you talk to people on park benches? How do you even find people?
So we get a lot of referrals from healthcare workers as well, and there's a referral form on the Safe and Sound website. It's
Okay.
Safe and Sound Grey Bruce / Palliative Care, I believe. Um, but yeah, so I'm also on an app called Hypercare where I'm connected to healthcare professionals, so I can get and social service workers as well are on there. Some people, so that's been good as well to get referrals. I think that's really great. Um, and yeah, being in Safe and Sound, I mean, a lot of people. I also get referrals from Grey Bruce or Bruce County Paramedicine, SOS. Um, I'm trying to think of housing, Bruce County Housing, Y Housing, Grey County Housing, just anyone who has, contact with people, and sees that, they're struggling to access palliative care because of, they're homeless or vulnerably housed, or, living in poverty, or have maybe serious pervasive mental health problems. And yeah, so I get a lot of referrals from all kinds of places. I also do, because I am in Safe and Sound, and I go out and about a little bit to where the people are. So that's another thing that I'm able to do with this job, which is great, is to just, sit down and talk to people. And a lot of it is about relationship building as well.
The expression you meet them where they're at, so
Hmm.
that if they're not in a particular location. My understanding from what you're saying is you go to where they are.
Yes, definitely. And that's what, like, sometimes I get referrals and it's like, we think we know where this person is, but we're not sure. And, they've been discharged, or, they've left the hospital, and it's like, this is their known locations. And can you help us out? And obviously if there's, yeah, so that's, uh, um, sorry, I lost my train of thought there. But yeah, it's I think it's really important to be able to go where people are, and I think that a lot of a lot of people in other agencies would love to be able to do that can't, and it's great that I'm able to go meet people and
Yeah.
yeah.
You know, as you're describing your role, I think of the primary, what you do is connecting the dots with the individual in the center, where you make sure that they get what the individual needs and what's available, and certainly it truly is a navigation. Now, from the time you've been doing this, now how long has it been now?
Since like the beginning of April, so
Oh,
it's
I've
a
got
very
the
very
week
new role.
Good, good, good. Any surprises for you? I mean, you take the role, but any surprises in what you've learned so far?
I mean, I think one thing is a lot of folks can seem like very very unwell, and you think that the trajectory is not good. And then when they get connected to care and services, they get better. So, and it's like sometimes all people need is primary care,
Yeah,
um, which is difficult and the currently to get people connected to as well. But I think that being able to fill those gaps is I can already see the benefit of it. Like we've had a few people that have been discharged because it's like they're in stable housing, they're getting kind of the care that they need. We don't think you're going to die, and it's um
yeah.
I think that's that's I think that's really wonderful that we're able to do that, and that's one thing you don't expect from a palliative care program.
No, no, but that's a hopeful sign, right? That
Yeah.
with the right navigation, the right interventions, that there can be hope for people who may have their path may have ended up elsewhere.
Hmm.
Um, I'm wondering, before we go on to more of the details, how can the community support you in what your work is? What are the practical things that someone who might be watching or listening can do?
Yeah, so one thing is that we receive donations at Safe and Sound. Donating to Safe and Sound is a wonderful thing to do. They put out specific recommend like calls for items for my program as well. Ensures is a really big one. A lot of people are able to access Ensures through their medical diet program, so that's great as well. But other people are not. So that's a big need to help people keep nutrition. Other things like incontinence products. We've had walkers and wheelchairs donated. I don't think we need any at the moment,
Mhm.
but that's a thing that comes up. So if you watch for the calls for that kind of stuff,
Yeah.
that's really important. Um, Also, the word palliative care, I think itself is scary for people, and they think that people don't want palliative care because they think that it means that you're dying, and I think, and obviously there's nothing wrong with that either but I think we're trying when we're talking about palliative care, it's anybody with a life-limiting illness, and the point is to improve quality of life, and that's not about hastening death. It's not scary. It's about improving your health and how you feel,
Yeah.
and how you're able to live your life every day. um, and other things that people can do, I think, are just there's I think a negative climate atmosphere often about some of the community in Irwin Sound and Grey Bruce, and I think it's really important to keep in mind that these are our community members. A lot of people I work with are people that I've known for a very long time growing up in this area. They're people that I've gone to school with,
Wow.
and people that I know, and people that maybe we don't people don't realize that this is our community, but it really is our community, and I want people to know that and understand. Um, and that's it's really important to be supportive and
And not to stigmatize,
not to stigmatize. Exactly. Yeah.
and
There's
not paint the actual picture. Yeah. So I want to talk a little bit more about quality of life. And the things that can improve quality of life. For example, if someone has a chronic disease and they have open wounds, not having proper care affects their quality of life. Am I right?
Yes, yes, absolutely. Yeah.
So if there's, and that can hasten a demise because of the risk of infection,
Hmm.
right? So what would you do in a case like that if you saw someone and they had that kind of situation? What could you offer them?
Like somebody specifically who has like open wounds and
Yes,
yeah,
yes.
yeah. So we have different supports. We have, a doctor in town, Dr. Cox, that specifically um, is there for folks who are homeless and at O'Share. And we also have the SOS team. We have Bruce County paramedicine. There's, some support through Ontario Health at Home as well.
Okay.
There are a lot of options for people to get seen for, the basic kind of um, like wounds and that kind of stuff. Because I as a navigator am not. Like I said, my degree's in equity, so I'm not doing the bandage
Fair.
changes and things like that generally. But we do have quite a bit of support for that in our area. And that I think we're very, very, very fortunate to have. Those folks, they all do an incredible job, and they're all really, really wonderful people. And I think that's that's really important part of our community and stuff. But yeah, when you're talking about quality of life, there's you have some people who are having chemotherapy and stuff like that, and not in a place where they're in somewhere where they're going to be warm for the winter.
Oh,
And that is, it's concerning for folks who are the colds. I don't know if you're familiar with um, what happens to your body when you have chemotherapy and you get very, very cold. So it's, can't hold cold things in the grocery store, for example. So obviously being outside in the cold and having that happen is very concerning. So that's um, just things that you don't generally, because people have somewhere to go. And if you have somewhere to go to get well, you're more likely to be able to get well. But unfortunately, a lot of folks in our community don't have somewhere to go to get well.
and that's important to understand. If you don't have a roof over your head and you're undergoing medical treatment for a disease, you're disadvantaged so many different ways. And we don't always realize, that they don't have an option. So I have another question, and this, not to put you on the spot, but end of life. For those people, my understanding is if people are terminal, but they are still actively using medication, drugs, that the services that might help them with end of life have rules and regulations that don't allow that to continue. What do we do with individuals who, at a time when they really need, the extra, but because they have addictions, um, are sort of still in that difficult place of getting how do they get the care they need?
Mhm. Um, so I think that is changing.
Oh, good.
Especially with programs like this. I do, and I've seen that with hospice as well. Like we have, the hospice in One Sound, and I've had some folks go up there, and they've been absolutely wonderful. So and I do think that that's changing, and I think that like I said, I'm not a medical professional, but we know that when people have higher tolerances, and so when people are in pain, they might not get exactly what they need from pain medications. There's also times when people go to hospital and they're in pain, that they're not given medications that would help them feel better because of their past or current substance use because they're looked at as drug seeking. But I think, reframing that as well is important, and thinking about, like, most of the time, or a lot of the time, people are using substances because they are in pain.
Yes.
So, how can we better manage that and support people so that they're getting the pain management that they need in an appropriate way?
And that is all about education and awareness and recognizing that those who are unhoused or precariously housed are disadvantaged, and we need to support them. Just
Hmm.
support everyone in our community with the services that are provided. We have about 4 more minutes in the program. Where do you see your service and what you offer? You're driving around a lot. Are you going to be the one who's able to handle? I mean, how many people would you have on a caseload?
Yeah, I mean, I'm right now, I think my kind of attitude about it is that when I do what I can, I do, and as much as I can, but I think that, that's going to have limitations. And I think that I only see the need getting bigger. Like this, like I said, it's very, very new position. I've had 24 referrals so far. I'm currently following 14 people. We've had 4 people pass away. And I think 2 that have been discharged. And then a few of those referrals that weren't appropriate, I think about 4. So, and then even when I get an inappropriate referral, it's generally, people who are frustrated and don't know where to go. So I try to help them figure out, who the appropriate person is for them to get connected with. Um, but yeah, I mean, and I probably see about 8 people once a week, and some people a little bit less. So it depends on their needs and how many appointments and things that they have. Sometimes we're able to schedule other transportation for people. Um, but yeah, I think really the future, there will need to be more navigators and more people to help. You know, there are a lot of people, like I always say, people with more needs need more, right? They are not, it seems like a very simple concept, but it's when you don't have a lot, you need a lot of support. And I think with our community being so large and the geography of it, I think that there's definitely a need for the program to expand, and there be more navigators and people doing the kind of the administration stuff that comes along with it as well. And um, yeah, I only see the need for this growing for sure.
And your role is, I've heard the expression, no, no wrong door. I mean, even if people aren't exactly sure, it sounds like you make sure they get to the doors that they need to, and that's part of your role. It's an amazing opportunity to enhance the quality of life for those of our vulnerable population, and also to be able to assist the public in knowing how to get help for their loved ones who may be unhoused. Less than a minute. How can people connect with you?
Yeah, so by email, it's a long, like my title. So maybe we can put that on the screen or something. Um, you can also call Safe and Sound. You can make referrals on the Safe and Sound website. You can call me directly. My phone number is available on the website as well. And healthcare professionals, if you're on hypercare, you can get in contact with me there as well.
Excellent. Kait, it's been an absolute pleasure speaking to you, and thank you for all that you're doing in your work, in your travel, and in your connecting people to the care that they need. It's an important role that you are doing. Thank you so much.
Thanks, Carol. Thanks again for having me.
My pleasure. And thank you to our viewing and listening audience today for joining us on HealthLink. Please join us again to learn more about programs, services, and resources available to you and to your family. Take care, stay safe.